Hi, I'm Meta Spencer. Let's go to Florida for an afternoon, shall we? I want to see my friend Pauline Rosenau, who's living there now at the moment. She's actually a professor of political science and public health at the University of Texas in Houston. But she's an emerita professor, which gives her more opportunity to go to her condo in Florida. So hello, Pauline. How are you?
I'm fine, Meta. How are you today?
Terrific. It's great to see you again after all these years. Actually, I should tell people how we know each other. We were at graduate school together in Berkeley long, long ago. And actually, we lived in the same building in University Village. And I lived at one end with my son, who was about 5 years old, and Pauline and her husband lived at the other end. And when I was studying for exams, I would usually read all night and then kind of sleep in the morning. So my 5-year-old would get up and go down to the outside their window and crow like a rooster. And Pauline would get up and fix banana pancakes for him. And he's never forgotten that. I'm not sure he's ever had banana pancakes since, but nevertheless, I remember that with great gratitude. So thank you for all those banana pancakes early in the morning, Pauline.
More than welcome.
I want to also include my friend and my assistant, Adam Nguyen, who is also with us today. Adam is a very important person in my life because he takes care of everything that I forget to do nowadays, which is a lot now that I have a 90-year-old brain. Good morning, Adam.
Oh.
Okay, good. Adam knows a thing or two about healthcare and health policy since that was his major at the University of Toronto. Okay, Pauline, now let's get down to work. One of the things that I'm sure people will want to hear about is your thinking about nursing homes, because I know that a number of years ago, you were on a commission that did a study of nursing homes comparatively around the world. I think for several years, you traveled around visiting nursing homes and writing reports of what you saw. Well, since then, of course, we've had a big scandal because the COVID pandemic has especially hit nursing homes hard. And Canada has a very bad reputation for its failure to protect elderly patients in nursing homes from the COVID virus. So let's go back and see if there's anything that you learned in all these excursions to nursing homes that would inform us a little bit about what should be done to make sure that our nursing homes were capable of handling things like this crisis in the pandemic.
We studied on a grant, a large grant from the Canada Council. I think its name is now the Social Science Research and Humanities Council of Canada. And there were 40 student theses that came out of this on how to improve nursing homes. But from my own observations, I observed in 5 provinces in Canada, nursing homes for a week in each province. And the group did it with me, and there were 6 professors in each site. And then we went to Norway, Sweden, Germany, and England. And in each of those cases, we compared what we had seen in Canada and the United States with what we were observing in the European countries. And many nursing homes were quite open to our observation. They actually welcomed us. They wanted us to write a report and tell them how they could improve the situation in their nursing home. And we did that for many of them. And they were very appreciative of it. But what I observed was, and when we ranked on quality, we found that the quality in the US was pretty much universally poor. And Canada was better. The best were in Sweden, and then the others were sort of in between. But the US was really low in terms of quality. And it's very difficult because children who want to continue working and not take care and continue their lives without the burden of elder care have to put their parents in homes that are worrisome. And that makes life difficult for everybody.
Well, is this mostly because of things like sanitation or not attending to physical things, or is it inadequate training of the staff, or is there insufficiency of staff, or what would be the silver bullet or the top priority for repairing the situation?
Well, I found that there was a difference in a different study on my own, that the nonprofits did a lot better in terms of quality, cost, and the service they delivered compared to the for-profits. But I'm told that that is no longer the case. And we didn't find it to be the case in the more recent study, that the for-profits were necessarily worse than the not-for-profit. That we've made nursing homes a competitive marketplace commodity. So the winner is the one that charges the lowest prices and pays the C, ends up having the most money to attract a name as the CEO representative. There's also been a consolidation of the market in terms of big companies buying many nursing homes, smaller nursing homes, sometimes combining them, sometimes just plain closing them. So people didn't have the choice of a nursing home near where they live. They had to take one further away if they wanted their parents in a nursing home. And that made it difficult to follow up and do what every child should do if their parent is in a nursing home. And that is go and visit and look to see what's going on. And be sure you don't put them in a nursing home where they say you can only visit from 10 till noon on Sunday. You can be sure it's the best meal of the week when people are watching. So go in and be sure you get the right to go anytime and pop in when they're least expecting you and stick around for an hour and just watch. And if the person, for example, as I did with the relative in England, doesn't have their own clothes on, but have clothes of somebody you've never heard of, but their name's on the tag, you have to ask, what's the matter? And often if you ask the staff what's the matter, they say, well, they give us so much to do that we can't possibly do it in the time allocated. And the ratio during the day can vary between one staff person and three patients, up to maybe at night, they'll pull back and make it 40 patients to one. So if there's an emergency and an ambulance has to be called, a patient is in distress, well, that person trying to take care of 40 people can manage one, but that emergency happens to 2 or 3 or 4 at the same time, it's a disaster, and the results are horrible.
Well, do they have things like a button that the patient can press whenever they have an urgent need to say, go to the bathroom or anything else?
Yeah, but the problem is the button goes off, and if it's at night, there's one person trying to do it for 40 people, and they can't keep up.
And you have some patients as well, or some residents that aren't able to use the button depending on their mobility. So if they're a stroke victim or something like that, they may not actually be able to access the button depending on how it's been installed.
Absolutely, that's so true. And little things like they have to, it's wise to keep hydrated. And what happens is where I have observed, they gave them a bottle of water with a flip top cap, but you had to unwrap it first, and they didn't know how to unwrap it. They weren't familiar. If they did get the flip tap open, they weren't used to it, so they would get confused and put the cap side under their nose, and then they had a hard time drinking and staying hydrated, and that's a death certificate when you have an older person with no access to fluids.
Yeah, and also there's another challenge with Parkinsonism and arthritis with some of those bottles as well. Just opening them, the act of opening them can be very, very difficult depending on people's abilities, and then certain conditions do make it a bit more complicated and also increases the risk of aspiration or choking with drinking water.
Yeah.
I had no responsibility really for my mother's care in the last 10 years or so of her life, but because my niece really lived near here and took care of her in California. But if I'd been responsible, I'm not sure I would have known exactly how to do it, because there's a gradation, I guess, of care services from what I guess are called retirement homes for older people, where there are some services. For example, I think people eat in the common dining room normally, but they do have, I know my mother had a microwave in her room, could fix certain things. So she lived in one of those, what are those called? But they're not nursing homes. There's assisted living, maybe. And then I think even within an assisted living facility, there are gradations of how much. Some wings have more caregivers than others and that kind of thing. Well, who determines what kind of institution a person really needs? Is it up to the family to decide where to put their mother, or is it does somebody appraise the health status of the older person?
Well, it's usually done in many places by a phone call, and it has to be a combination. Does the person have insurance? If so, what kind? Do they pay out of pocket? That is cash. And then you have to pass the next stage, and the next stage is the facility. My British friends laugh when I say facility. That's what we call nursing homes or assisted living facilities here. In Britain, facilities means the bathroom. So okay. The facilities, they say, no, it's down to the left when we walk out to the bus. Kind of confusing with the difference in terminology. You have to be accepted by the facility, and that means they will do a checklist and they will tell you we aren't equipped to take care of a person who needs that much help, or we can take that person, but you'll have to pay $125 extra to have someone sit at the table and feed him or her, because we've determined they can't feed themselves. Mm-hmm. Or if they are unable to come to the dining room, then there'll be an additional charge. And if your parent needs diapers, then there's an additional charge, and that might be in a different section. And if you're with a spouse, then it becomes complicated because you have to have a gradation of the needs of both members in the spouse. Mm-hmm. And what happens, and I've seen this happen, when one deteriorates more quickly than the other? Well, they will have a dementia unit. The care there, again, will be more expensive, and they may offer, for the spouse who's not in the dementia unit, there may be enrichment activities like painting or sculpture a couple of times a week, or they have a little bus that will take you to a shopping mall nearby a couple of days a week for a few hours. You can pay the staff extra to go out and pick up something, a birthday cake or whatever you'd like to have. But those in the dementia unit have much less freedom, of course, because they can't make decisions. And we visited one in Britain where in the dementia unit, they had it set up in a circular fashion with a track all around the circle, so the patients could walk because they wanted to walk, but they couldn't go outside, and they didn't have a staff member. So they just told them to walk in a circle, and they'd always come back to the same place. Well, sometimes they thought they were in a different place, but at a certain point, their dementia was such that it just kept them active and gave them exercise. And some of them literally developed the kind of dementia that meant they couldn't be still. So they had to walk. Their brain said walk all the time, but they couldn't sit down to eat. So the nurse went, really, this is wonderful. Hand them a sandwich or something they could eat with their hands as they were walking, and they passed the nurse's station. I would have never thought to do that. So they arranged in a lot of the best places where you pay the most, quite innovative solutions to problems. Mm-hmm, mm-hmm. In some places, they wouldn't let people out of a wheelchair because they weren't safe. In other places, they said, we require that they get out of the wheelchair and we will walk with them every day so they can exercise because it's so important for their health.
How do you ensure that there is engagement in a social manner for the residents and that they're not isolated within a group living facility? And I think culturally sensitive care may play a role in this, but also just how do you make sure that they aren't having either emotional, mental, or social isolation from other people?
A lot of the older people, they still were more comfortable in their native language, and it could be Spanish or some language that's not common to English-speaking countries. So there you have the problem of matching the patient to the language, but that too is critical for social activity and social interaction. Many of them organize games and bingo or other kinds of games of that nature, Monopoly, and they'll have those different days of the week. And people can sign up for them, or sometimes there's no need to sign up, just show up. But I've seen all kinds of innovative ways to get people to interact and get them out of their room. And people will, in a good nursing home, top nursing home, they will take notes. And if somebody doesn't come out, and they can, in many places, order their meal to be brought to their room if they're not feeling well or if they just want to eat by themselves. But if that goes on for a certain length of time, a good nursing home will have a social worker. We'll go and have a chat and find out what the problem is. It may just be that they don't like Mrs. Smith, who they're sitting with. And by switching them to a different table, they will be happy to come and have their meal with the group.
I have a dear friend who has dementia and is in a very swanky retirement home with in a special wing for dementia. But she complains all the time about hating the place and about how it's really a prison camp, and they treat it, well, it probably is, you know. She can't probably leave on her own and do things that she wants to do. So there is a sense in which it's not all that free. But, you know, she's miserable. I wonder how many people are happy and how many of them are unhappy in these settings.
It's very, very different from individual to individual. Some, for example, couples are so happy to have the burden of taking care of the spouse that's not doing well. They're delighted to be able to play bingo, to go to the supermarket with the little bus, to bring the thing, to buy themselves whatever treats they like. And and that's just a big burden off their shoulders. The person that has dementia may not be so happy because of the restrictions, and they're justified basically by the organization or the institution where they're living by the need to protect them from the outside world. That's a philosophy that differs. Some people say, let them do whatever they want. And then if you say, well, they might be hit by a car crossing the street. And in this philosophy, they say, well, you tell them to turn, to look left and look right and wait for the green light, but you don't protect them any more than that. And if they get killed by a car hitting them, well, so be it. But the other philosophy is the philosophy of high protectiveness. And they may have a yard with a fence around it with grass, and they can go out there. The most important thing for children and their parents is to anticipate the need for this, to assess their finances and see what they can afford, and their personal desire to stay home or to live in a collective situation. Some nursing homes will let you come and visit for a couple of days. You can bring the mother or the father, your parent, and they'll actually have a room where they can stay 3 or 4 days, take meals with the group, and see what it's like. That's not as frequent as it used to be because the demand for nursing home beds is so high now. Mm-hmm. Or you have to find a place. And if you have a parent with some kind of problem, it's sometimes extremely hard to find a nursing home that will accept them. Mm-hmm. Because of course they'd like to have patients that don't demand too much so that they don't cost the nursing home so much to pay for them. The other problem we found was the assistive nurses, the people who do the real person-to-person work. They are hardly ever paid very much, and often their training amounts to a 6-week course. And that's at best, that's the top. And sometimes just do a 20-minute video training on the internet before you come in. Mm-hmm. They for COVID now, which complicates things even more. People can call up and say, I tested positive for COVID, so I can't come in for 2 weeks. What do? You didn't anticipate that. And if you're trying to manage your finances from the point of view of the owner, you don't exactly have a lot of staff there's some places in some states, in some provinces, where the rule is you have to have a certain percentage of your staff, like 70 or 80%, who are trained and fully qualified assistant nurses. But not, and then they can say in an emergency, we can make an exception. You just have to file a notice, that regulatory notice. But the rules vary from place to place. When you go in to see a parent, the most important thing is look at their skin, turn them over, see if they're developing bed sores. And if you see something like that, report it to the agency that monitors quality of nursing homes whatever part of the world or country you live in. But if you don't do that and you're counting only on somebody else to do it, that's a mistake.
I wouldn't know how to look for somebody's bed sores. I wouldn't know a bed sore from a.
You can Google it.
I remember my mother-in-law had dementia and was in a nursing home, and she had an ankle bracelet, as I recall, toward the end, because she would run away. She would say she's escaping to Mexico. She'd get out the door and she'd down someplace. They'd find her down the street someplace, trying to go to Mexico. And so they put I think it was something that would activate a buzzer. If she went through the door, they could notice that.
All kinds of other devices now, even more are available. And there are apps on the internet. If you can get the person to take their cell phone with them, they will allow you to see exactly where that person is. Mm-hmm. And to see where you are, so they can get back home and you can find them if they get lost. Mm-hmm. And what's your philosophy? Take a little risk and give them a little more freedom, or make them very safe and restrict the freedom?
The COVID epidemic has certainly affected nursing homes, I suppose, almost everywhere. But I wonder if you know any differences, or has anybody been able to say which countries are doing a better job, or what needs to be done to improve the survivability of a nursing home during a pandemic?
I have not looked at that intensively, but the most important thing is to be sure that your staff is vaccinated. And right now, that's pretty much left to the employer. President Biden in the United States has just suggested that people who work for the federal government have to get vaccinated, but it's up to the employers to decide whether or not they're employees, and that would be a nursing home. And there's certain rules that apply to large corporations and some that apply only to small, below 20, for example. And I can't remember the difference. COVID brought a lot of problems, Meta. Those are worth talking about. And it's very important for nursing homes to have their employees vaccinated.
Absolutely. I can't imagine why in the world it wasn't immediately decided that everybody working in any kind of healthcare facility and anybody coming or going from the building must be vaccinated as soon as vaccines were available. But even then, afterwards, using masks, I don't understand why that is such an issue. It strikes me as almost crazy, really, to allow that kind of safety hazard to continue to exist in the name of freedom. I mean, my God, John Stuart Mill was, I don't know whether he's the one who said, your right to swing your arm ends where my nose starts, or something. I think that was, somebody invented that analogy that, you can do what you please as long as you don't harm other people. But if you have a disease that's going to sicken or kill other people, you don't have the right to go around, doing that to people, exposing them. And it seems so obvious to me, so patently obvious, that I can't imagine how anybody could think otherwise. I mean, I don't understand any argument to the contrary. And
I agree.
Yeah, I think most people do, but not the people who want to say that their right is to infect other people with diseases. Anyway, there we go. I've completed my rant. Let's move on. I get out of control now and then. I have to express my values. So let's, now you are sort of an expert on different ways of covering the cost of insurance that different countries have. Very frequently, we hear a comparison made between the United States and Canada. I mean, especially during elections, the US people are always talking about, look at Canada, look how good they are. And yes, by comparison, I think the Canadian system is vastly superior. And there are better countries in the world, I think France being one. But in terms of the effectiveness of the healthcare system and how it's paid for and how economically rational it is. But if you live in Canada, you hear complaints about what's deficient here, and so it should be. There's always reason for improvement. Tell me what you know about the different healthcare systems or insurance coverage systems that different countries use, and which ones you particularly recommend.
Like you, Meta, I have lived a long time in both the US and Canada, and I've also lived a little while in Britain and France. So we have a good basis to compare. And I was happy. I had a baby in the Canadian system and didn't get a bill for anything. I have friends who've had children in the US and thought they had insurance and ended up paying $10,000, $20,000, $30,000 for care that should have been covered, but the insurance they were underinsured, they had been talked into a policy that didn't cover the care that they were going to need. In the United States, we have Medicare that starts at 65, that covers pretty much everything if you paid into it. Not all older people have done so. Not necessarily, and it depends on if you worked and were self-employed, and there's some requirements that you have healthcare, but not everybody is covered. So insurance is critical. Without insurance, people hesitate to go to the doctor if they're ill. And that's caused a lot of problems because people who thought they might have COVID, but didn't have time to go to the pharmacy to get a test, didn't have the money to pay for the test, which is not free in every state. They were left with a situation where even if they were sick with COVID, they didn't go to the doctor and they passed it on to other people around them. The idea of wearing a mask, staying outside, it's still the best advice. So those trips to the supermarket were sometimes okay for nursing home folks. But getting back to the insurance coverage. So basically people didn't know and don't know, even now, the full extent of what their coverage is and if it's adequate. And we used to have navigators who helped out people who had to choose their health insurance on the online market in the United States called the ACA. And those navigators would give them help, but the funds ran out for that, and the Trump administration didn't renew it. So again, those people were managing on their own. Some made good decisions and were able to, others did not. Where they did not, it usually ends up that the state or the government at the state level pays a lot of their care. If they're pregnant, then they get free healthcare by mandate from the federal government for the states to take care of that. And how the payments divided up between the federal and the state, I don't know. But it starts from the time the woman knows she's pregnant, 3 or 4 months, until about 6 or 8 weeks after she delivers.
Now, wait a minute, you're saying that all pregnant women do have free health care in the US?
I believe that's the case. I'm 99% sure, but not 100% sure. It doesn't last after they've given birth. And so they are back where they were before. And in many states, you have Medicare, Medicaid, and then you have a community clinic where you can go if you don't have insurance. We have a lot of people in Texas, for example, and in Florida, who are undocumented. They don't have legal status to reside here. And they end up going to the community clinic, which you may or may not, many of them were closed during the COVID epidemic, and some of them stayed open, some of them went online, a whole variety of different solutions. But the bottom line is, during the COVID period, we weren't interacting with each other as much as we are now because so many people are vaccinated and societies are opening up. So the question is, do we have a high enough vaccination rate to say, okay, you can interact with each other, but the insurance link is still there, and it's there before COVID, and it's there during COVID, and will be there after COVID. You have to have a good insurance. And there's another problem, and that is the problem of having insurance that's too good for your own good. Unless
What do you mean?
It's too good for your own good.
Really?
There's some there's some doctors who think that everybody needs a hip replacement, even if it's just or a knee replacement. I was told I needed a hip and a shoulder replacement. And I said I need to get a second opinion. And I got a second opinion. And both of the doctors that gave me second opinions, both for the shoulder and the knee, said, it's not true. You really don't need that surgery. Boy, was I glad I got a second opinion. But in the United States, it's up to you to do that on your own. And the insurance companies often will not question it. That's what shocked me. They'll just approve it. Your doctor approved this procedure. So, you can have it.
Mhm.
I just want to, jump back to what you mentioned about undocumented migrants who are accessing the medical care system. We had a situation here in Toronto's Chinatown with a vaccine clinic, and they were requiring forms of government identification to get people vaccinations. And there are undocumented residents in that neighborhood, or people whose immigration status is shaky, or people who have very high hesitancies when it comes to engaging with the government system due to experiences in other areas. So how can we get people who are not within the standard definition of a medical framework when it comes to, policy implementation? How can we get them access to these life-saving interventions like vaccines without putting their safety and lives in jeopardy?
I didn't know that was a problem. Yeah.
Oh, yeah. In many places at the state level, when they started out giving the COVID vaccine, they gave it to anybody who presented and said, I want it and I haven't had it. The person was given a little white card, the CDC card, and they didn't even put the person's name on it, didn't take their social security number, and you just had to be sure you kept your card so you could come back and get the second dose. And you put your name on it. You could be Susie John and nobody would care if you were really Sally Smith. That's it. It's gotten a little more difficult, but again, it's in society's interest everybody be vaccinated. And in many communities, there's such a deep suspicion of the government doing anything that people hesitate to go and get vaccinated. Even if they have all the documents in the world, their suspicion is that the government will be trying to get them. And if they have their information, even if they have the proper documentation, they may have a brother or sister living with them who doesn't. So worried that somebody will knock on the door and say, how many people are living here, etc.
Mm-hmm. Yeah.
And then there's also the legacies of sterilization and eugenics in some communities, particularly Indigenous communities in North America, and then also within the African American community, the Tuskegee syphilis study and things like that, where people were experimented on medically with injections and other forms of interventions without being told what was going on. And those legacies are still very, very prominent in some communities' living memories.
Yes, and anybody who goes online and things like Facebook or Instagram, I don't subscribe to those media, don't have time, but I understand that there's a lot of information, some of it's false, about how this is a vaccine that's put out there by the government to sterilize the Hispanics, so we won't have more children. And those are hard to combat. You can have leaders from those communities be on local television. Mm-hmm. You can have people go around from the community and hand out a flyer saying, here's where you get the vaccine. I'm African-American, you're African-American, you can trust me, here it is, this is the information, this is where you go Saturday morning, 9 to 5, we're giving donuts afterwards, all kinds of things that you can do, little ways that work in different areas. And it's up to the states for the most part to take care of that. And it's also up to the states to report their COVID levels and what's going on with the percentage of vaccinated and percentage of people dying from COVID. And some states report regularly, systematically, and efficiently, and other states don't report at all.
Well, it sounds as if you're saying that a lot of ethnic minorities or Indigenous people have a real suspicion enough to put them off and keep them from taking advantage of services that are really available and that they should be using. Well, that, as somebody with no experience along those lines, it's shocking to me that there actually are people who are thinking back. The Tuskegee experiment was what, 100 years ago or a long time ago. It's not something that anybody would need to worry about now, but still, if it's enough to put people off. One thing I saw that was very intriguing to me was, there are apparently, I don't know where this is, but there are certain barbershops where mostly black men go get their haircut. And so in some places they've set up little stations in the barbershop where they'll check your blood pressure and 2 or 3 other things. Maybe they'll even give you a COVID vaccination now. I don't know. But it struck me as very clever that you would go to a place where people just hang out anyway and are more comfortable and not in a frame of mind to be suspicious. Yep. That strikes me as, we could do it in hair salons too.
Yep. And I think that's proven to be a very effective way to get communications out to the people that need to hear it. You were talking about the Indigenous people in Arizona and Utah, and I've seen on television and they covered this on many of the national news, even though it was the original. They have the tribal leader be vaccinated on TV. Mm-hmm. So, and the tribal leader may have 2,000 or 3,000 people. Mm-hmm. Some of them are small, 200, others large, but having one of the leaders that you trust from your community, be it African American, Hispanic, or a tribal leader from one of the Indigenous people, mm-hmm. that helps. That really works. That's an effective way to get
them. But I can give you a counterexample that I heard about recently, though, which is that actually Trump made a public announcement that he had been vaccinated, and he recommended that his followers all get vaccinated. But it apparently hasn't made any difference at all. Even the people who love Trump are not willing to get vaccinated because Trump tells them to. Now that really baffles me. I would think that he's the one person who might influence these people. Do you understand that? I don't.
Adam, what do you think? I have no answer to that. Well, if I was a Trumper, I would expect that if Trump told me to go get vaccinated, I should do it. But he didn't say it. I watched that program where he did it.
I didn't see it. I just heard it.
I saw it, and then they ran it over and over again on a couple of the news channels. But he didn't say it in a way that would make you think he really believed it. However, the fact that his behavior matched his discourse or his jargon made me think I would have concluded he did make it. He did really mean it. But for the people who listen to it, many of them could say, you see, it's just a fraud. The government is putting this on. Our tribal leader didn't really say that. That's not really him. You watch, the camera will wander away just a little bit, so you can't see if it's really his shoulder or the shoulder of somebody else the needle is going in. I've heard a lot of this.
Really? No kidding.
Any of that?
I'd be curious to see if anyone has studied how these perceptions of vaccines and conspiracies around vaccines propagate within certain sub-communities. So Trump may have got vaccinated, but how do his followers encounter information about the vaccines, and how does that propagate within their networks? And is there a source? So maybe their leader, President Trump, got vaccinated, but is there a source that is more present in that community that's overriding that event that they witnessed? And how is this information propagating within not just the mainstream discourse, but kind of the sub-discourses that you get within some of the more fringe, I shouldn't say fringe, that might not be the right word, but within some of the other groups that you see, particularly within the right wing. And I just want to add, you did mention going directly into communities to vaccinate people who may be marginalized. I heard a fascinating example that's ongoing here in Toronto of targeting vaccinations of sex workers who are very, very marginalized when it comes to healthcare systems, HIV prevention, STI testing, but they're going directly into bathhouses to vaccinate people who would not otherwise get vaccinated. And I thought that was a huge intervention to get people who are engaging with a lot of people who already have a high risk of disease, but going directly into these spaces that people wouldn't associate with this direct form of medical intervention and providing it to them right then and there, no questions asked. But I thought that was a huge bridging of a gap for community that wouldn't otherwise have access to this intervention.
Yeah, good point.
Mm-hmm. Yeah, I think with regard to the question of why people are anti-vaccine, I think it's like if you were looking at it as a survey analyst, what is the preceding antecedent condition that explain both variables? That is the support for Trump and the opposition for vaccines. I think it is something about hating elitism and science. And normally, you see, Trump was somebody who opposed science. So that's why they support Trump, because he's in favor of ignorance, basically, normally. But you see now, he was actually somebody who could have taken a lot more credit than he actually claimed for the development of vaccines, because this miracle of the rapid development of vaccines took place under his presidency. So he could say, look what I did for the world. I mean, yes, I may have screwed up other things, but look, I did at least produce an amazingly fast production of vaccines. But he doesn't claim that very much. But nevertheless, here he is saying, yes, I did get vaccinated. So he's clearly promoting vaccine to that extent. But the thing is that these people are really substantially opposed to science and to and therefore to medical science and to vaccinations on that basis. So it's an independent source of opposition, I would think. These anti-vax people are a class by themselves in terms of, which I don't fully understand, but I think it has something to do with the sense that these guys think they're so smart and they think we're stupid. And therefore, I don't like people who are scientists because they try to make me feel inferior. That's,
You're right. It's coming together of many, many different values. And science is one, and Trump agreed with that, even though he got vaccinated himself. And there are many other components to this philosophy, and we saw the results on January 6th as these people tried to invade the Capitol, and they did. They succeeded. Nancy Pelosi's chair. A sad day for Americans.
Well, this is, we could go off into a whole discussion of this because it fascinates me endlessly. But you and I were talking about our friend Arlie yesterday, Pauline, because we have this common friend from graduate school days who's written this book about strangers on their own land. And I think her analysis is absolutely right, that it is a sense of being displaced in the status hierarchy. It isn't really specifically about income or social class, because there are many, many rich people who have this sense of having lost their ranking in the social status hierarchy, and that kind of resentment is probably a large part of the explanation, again, of opposition to highly educated experts, because they experts, medical or any other kind of professional experts, get status that they feel they're losing, and they're being displaced by.
There's a lot of research on that, and it does definitely show it's relative, where you rank relative to those around you and those you respect. And if your position, you're being pushed to the bottom by other people who are increasing their social status by moving up. Whether they're richer or not doesn't matter. What matters is that they look down on you, or they feel individuals. They're now being looked down upon by those who are socially mobile and moving up, no matter what their ethnic group. But sometimes it's characterized with an ethnic identity. The Blacks are moving up. They're getting uppity, and that leaves me, a white poor person, lower down in the spectrum relative to where I was before. that's an example, a nasty one, but I've heard it and I know it exists.
Yeah. Okay, let's switch back to where I asked a leading question a while ago about asking you about different kinds of financial arrangements for healthcare systems. The comparison between what I think is called the single payer system that presumably Canada has, and these insurance company system that I think the US has. And then I believe there are other systems elsewhere. Now, you referred to something that I'm embarrassed to admit that I don't really understand. Like you referred to two things, Medicaid and Medicare, and then something else, which everybody in the world knows what that means except me.
Yeah.
Tell me what those are and what privileges go with them and who gets them, et cetera, in the US.
It's confusing because in the US, we use the term Medicare to refer to the program that covers generally, with a few exceptions, anyone over 65. And then we have Medicaid, which is, and that's paid for by the federal government, but mostly by the contributions people have paid into the system through their employment over their lifetime. And Medicaid is a system that pays for the healthcare of the poor. It's paid for largely by the states, but they get money from the federal government. Now, 40 states, and when the mandate to cover Medicaid patients or people who are eligible for Medicaid it came with the Accountable Care Act, 40 states asked the federal government for some role in organizing their Medicaid program for the poor. And they had the choice of signing on for a boilerplate kind of program with the federal government, or negotiating a separate contract with the federal government to give them more power to take on more responsibility. 40 states now have done that, but 6 or 7 states have asked the federal government to run their Medicaid program. They said, we'll give you the money, you just take care of it. And that's the way it works. It's different at every state level. And there are so many varieties that nobody's even written a book about how each state does it. And it changes all the time because these contracts have to be renewed, and every couple of years they have a period of open enrollment for individuals, but it's the same for the states. They can renegotiate. And if Biden gives them a better deal than Trump, they might go with that program this time. Adam, anything to add about the Medicare in Canada, which applies to everybody from birth? And again, I know lots of paperwork.
Other than we do need to expand the system to offer more coverage for things that are not currently entirely covered by it, like some medications for people within a certain age bracket, or dentistry care or eye care. It does certainly need a revision to a certain extent to be more comprehensive. One issue that with the Canadian medical care system, and this is not just isolated to that specific system of Medicare, but we have large distances in this country between communities, and in the north and in remote areas, the healthcare coverage and healthcare accessibility is horrendous. And the life expectancy is much lower in some of the more remote and rural areas. And I'd be curious to hear your perspectives on how we could maybe address that. I know they do have financial incentives to try and get medical workers up into the remote communities. It doesn't always work, and it doesn't always retain them. And I'm wondering if similar things may exist within the United States. I've heard some of what you guys, I guess, call American Indians or Indigenous people, but we call First Nations here within some of, say, the Navajo reserves, or in the Alaska context. There's similar situations, but how can we maybe increase the accessibility of healthcare within remote and rural areas? Because that, I think, is another whole gap and a whole other situation and struggle when it comes to providing healthcare to large percentages of our populations in both the United States and Canada.
It's difficult, especially when you have people who live in rural areas that are far from each other. And that's true in the United States. It's true in Canada. I had a student who graduated with her master's in public health in Texas. She was a doctor from Montreal, and the health system there would pay her to go to the Great Northern communities near the Arctic Circle, and she would just stay there, and they would book the appointments solid for her 6 months before she came, and she would see patients one after the other for a whole week or maybe 6 weeks on some occasions. She even brought her family with children with her when she was breastfeeding. And so that was an interesting solution, and it worked for a lot of those people. In some cases, the tribe paid some of it. And in some cases, they would ask to have her come back because they really liked her and her low-key way of approaching them and with respect. And she was really good at that.
Yeah, I have
That's
a
very
doctor
interesting.
friend who goes to someplace in the north. I think one week out of every month.
That was something along those lines.
Uh-huh. But of course, if you get an attack of, appendicitis or something without warning, then what happens? I guess you called for a helicopter or something. I don't know how much something like remote location actually has an impact on mortality or morbidity. I mean, how much risk are you at for living in a place where you don't necessarily have quick access to an ambulance? I don't know. Has anybody looked at the life expectancy or other such factors with respect to location?
The emergencies that you talk about are serious, and there's often no way to get the person to the place they need, although they do have the ability to call in a plane to pick them up and then bring them back to Montreal, in the case of Quebec, for surgery. And they could have sometimes, part of the airport is dedicated to that air ambulance. So, they pick them up at the airport and take them to the surgical unit immediately. Ironically, we have the same thing here in Florida for Canadian citizens who sign up and get insurance through a certain insurance company. And part of that, and in Mexico, where a lot of Canadians spend a lot of time, you can sign up for the air ambulance. And in case of emergency, they will fly you to Montreal. For small things, they have local people. And as we do in the Great North, in Quebec, for example, they have nurse practitioners, and they're training more, and they're trying to urge them to stay in their community once they've been educated, and they pay for their education at nursing school. And so if they complete their nursing degree and they are nurse practitioners, they can deliver babies in most cases, and they can tell you several weeks before, this is going to be a difficult delivery, and we have to get you closer to a hospital before you go into labor.
You also must have other countries that you've studied the healthcare system. I mean, I think a few years ago, Michael Moore did a movie about healthcare systems, and I think he said that France was the best. Yep. Is that true? And what makes a country better than Canada, for example?
I think a lot of people complain about the waiting time in Canada. And they don't want doctors and hospitals and nurses to waste time. So if you're not urgent, the urgent patients go before you. And so you might have to wait longer than you would in some place like France, where they have more hospitals per patient or hospitals per doctor. And but that idea of it's okay to wait, we're part of a community. We don't want anybody to die because we're going to have our ingrown fingernail taken off and somebody dies. You don't have that kind of selfishness that says me first, no matter what. It's we're all in it together. Let's do the best we can for everybody. And that's the way they work it. And I think it's impressive. And it's the same that we observed in Germany, not perfect. And certainly people fall through the cracks. And we found Sweden was very good. Sweden has a nursing home policy that's different than most, and that is that you stay at home as long as you possibly can, and they will also give you the possibility, if you want it, of staying not in a large nursing home, but in a family setting. And some families will take in a person who's older and needs help for the money, but they do observe how it's going, and that everything is, nobody's really getting exploited. And there's not enough inspectors. There should be more, but they do well, and they are largely seen to be very positive.
Mhm. Well, I have just spent several weeks in the care of something that I had never discovered before. My family doctor referred me to this thing called Bakerest, which takes care of older people. And they have a team that you talk about excess care. Honestly, I got so much attention that it was almost annoying. They were bugging me all the time, trying to help me out when I'd had all the help that I could absorb. But they have people who will come and check, how far do I have to reach to turn off the faucet in my bathtub? And is this a safety hazard? And et cetera. They recommended a hospital bed. Well, I figured I don't really need a hospital bed. I improvised something that works just as well. But nevertheless, they wanted to make sure that I had all the facilities, if you can excuse the word, that that I needed as an old person, which is just really wonderful. And they would call me and make me get out of bed and do exercise with them. And a lot of these people are sitting in their wheelchairs doing exercises, and they're not exactly strenuous exercises. It might be you twist your wrists like this, you think, why are you bothering me to get out of bed to do this with you, Anyway, I highly recommend it, but it would be, I'm sure the amount of medical expertise that I was absorbing would be way prohibitively expensive, too much to offer everybody in the population. But because it really, I had teams of 6 people at a time spend an hour with me interviewing me. You'd be an occupational therapist and a physiotherapist and a nurse practitioner and a this and a that, doctor, a geriatric physician, even legal advice if I needed to change my will. It's really quite
wonderful.
amazing. Yeah.
Very impressive.
Yeah.
And it is expensive. And the reason that they do it is they have discovered for every dollar they spend on that, keeping you out of the hospital, keeping you fit and keeping you home saves them several dollars.
Mm-hmm.
And so it's a cost benefit analysis, and it works. And they will point out to you the things you need to change to be safe at your home. And they're hoping that you can stay there. Bakerest is excellent. I visited that hospital and we interviewed other people there. Good philosophy and excellent performance, in my opinion. Yeah.
Okay, that's terrific. Well, I think we've covered the waterfront today. We've certainly covered the medical care institutions of Canada and the U.S., if nothing else. So it's been fun and always a treat to have a chance to get to be back together with you and chat, Pauline. Thank you so much.
Nice to talk to you. And thank you, Adam, very much, both of you. Hope you have a pleasant rest of the week, and I'll say goodbye for now.
All right. Bye, Pauline.